Hello, and welcome to the decision support video for patients with rectal cancer faced with the option of surgery. This video is right for you if you have recently been diagnosed with rectal cancer and your doctor has suggested surgery to remove the tumor. Before we get started, let's take a few minutes to introduce you to some of the features of this program. First, you can pause the video at any time and either continue from where you are or come back to the video later. You can also use the sliding button to move forward or backward to different sections of the video. To view in full screen mode, you can click here. To escape full screen mode, you can simply press the ESC or escape key on your keyboard. You will be asked to answer some questions in the Questions and Answers panel. Once you complete and submit your answers, you will then receive an email that contains all your answers. You can print out your answers when you see your doctor. If you have any questions or comments, you can record them on a notepad and bring them to your next visit. Your healthcare team will review your answers and comments and answer any further questions you may have. Now let's get started. In the first part of this video, we will review general information about rectal cancer. In the second part of the video, we will review 2 surgical options. In the last part of the video, we will review the main risks and benefits of the surgeries. What is rectal cancer, and why is rectal cancer surgery so difficult? Rectal cancer is a tumor located in the last 15 centimeters of the intestine. It is a difficult cancer to treat because of its location. The tumor grows in a very narrow space between the tailbone, the prostate, and bladder in men, and the tailbone, and the vagina in women. Also, the tumor grows very close to the muscles that control your bowel movements here, and the nerves that control your sexual and urinary function here. These nerves are as thin as hairs and can be difficult to identify. They are at risk of being stretched or injured during the operation. What are the goals of rectal cancer treatment? The first goal of treatment is to remove the entire tumor for the best chance of a cure. The second goal of treatment is to balance the risks and benefits of surgery, keeping in mind your medical health, risk of complications, and treatment preferences. The third goal of treatment is to minimize changes to your bowel, sexual, and urinary function that are at risk with many of the treatments for rectal cancer. Your surgeon may have offered you one of 2 options for your surgery. The first option is called anterior resection. The area of the rectum where the tumor is removed. Then the 2 healthy ends of the bowel are put back together. Your surgeon may need to create a temporary stoma or bag to allow the new connection to heal. This temporary stoma or bag prevents stool from going through the new connection, lowering the risk of infection. The temporary stoma produces more liquid stool with little odor. The timing of the stoma closure is at the discretion of your oncology team and usually occurs once you have fully recovered and completed any additional necessary treatments. The second option is called abdominoperineal resection, or permanent stoma or bag. In this situation, the tumor cannot be removed without removing the whole rectum and anus. Once the rectum is removed, the healthy end of the bowel is brought out to the skin and a bag is attached. The rectum and anus are removed as one piece and the anal area is sutured closed. Following recovery, bowel movements will become more regular and predictable, for example, morning and night. The bag controls smells and release of gas. Regular stoma care is necessary, such as cleaning the area, changing the bag, and applying creams. The cost of these materials may be covered. Most people resume their normal activities. Why are the bowels not always reconnected? When possible, reconnecting the bowels is commonly offered. It may not be possible if the tumor is very large, if the tumor is spreading outside the rectum, if it is very low in the rectum, and if you have any problems with controlling your bowels before surgery. Your surgeon may not be able to predict until the time of surgery whether it is possible to reconnect the bowels or not. Blocks of 100 faces show a best estimate of what happens to 100 people after surgery, and up to 2 years after, who have their bowels reconnected or a permanent colostomy. Each face stands for one person. The shaded areas show the number of people affected. There is no way of knowing in advance if you will be one of those affected. You should discuss with your surgeon if you have any risk factors for these outcomes. Risk of having a permanent stoma. With an anterior resection, the majority of patients have a temporary stoma that is reversed. 15 out of 100 people will not have their stoma reversed. With an abdominal perineal resection, everyone has a permanent stoma. The 15 people do not have the stoma reversed because of personal choice or complications following surgery. Risk of leak at the bowel connection. If your bowels are reconnected without a temporary stoma, your chance of the new connection leaking is greater. Up to 11 more people without a stoma will have a leak at the connection site. A leak at the connection site can be a life-threatening emergency and may involve more treatments, more surgery, treatment in the intensive care unit with life support, a longer hospital stay, a longer recovery, and a small risk of death. This can be avoided in most patients by making a temporary stoma that allows the connection to heal. Risk of incontinence. 35 more people who have their bowels reconnected will complain of accidental leakage of gas or stool. All of these people choose to wear a protective pad in their underwear. Accidental leakage of gas or loose stool is most common. Accidental leakage of solid stool is the least common. The following is some additional information about the risks to your bowel function. Risk of multiple bowel movements per day. Your bowel function after surgery depends on a lot of factors, including surgery, your bowel function before surgery, and whether you had radiation. Each of these factors can increase your risk of having problems going to the bathroom after surgery. You should talk to your surgeon about your particular risks. What types of problems do people experience after having their bowels reconnected, and how common are these problems? 20 out of 100 people have 4 or more bowel movements per day. 25 out of 100 people will have to go to the bathroom at night. 35 out of 100 people will have problem holding a bowel movement in while trying to find a bathroom. Risks of urinary and sexual problems. Some people who have either surgery report worsening of their urinary or sexual function. The number of people who report this problem is the same for both surgeries. Urinary problems may include difficulty peeing, accidental leakage of pee, and peeing more often. Sexual problems may include impotence, ejaculation problems, difficulty with arousal or orgasm, vaginal dryness, and pain during intercourse. Complications of a stoma. With either surgery, you may have a temporary or permanent stoma. Complications of a stoma include hernia around the stoma, too much bowel sliding through the stoma, bowel sinking under the skin, skin irritation around the stoma, wound problems where the anus was sewed. The following is some additional information about the complications of a stoma. Risk of a peristomal hernia. On average, up to 50 people out of 100 will develop some degree of hernia around the stoma opening. This peristomal hernia develops because of weakness in the muscles of the abdominal wall around the stoma. A peristomal hernia can lead to a bothersome bulge next to the stoma, difficulty putting on the appliance or bag, also called pouching, pressure or discomfort in the area of the stoma, and rarely a blockage of the bowels. These problems are usually managed conservatively without surgery. Risk of stoma prolapse. Up to 10 out of 100 will have too much bowel sliding out at the stoma, called stoma prolapse. Stoma prolapse can lead to swelling of the bowel, making it easily irritated, sometimes leading to minor bleeding. These problems are usually managed conservatively without surgery. Risk of stoma retraction. Studies report in up to 25 out of 100 people, the stoma can sink back under the skin. This is called stoma retraction. Stoma retraction can lead to difficulty controlling the fluid leaking from the stoma and can lead to skin irritation. This is usually managed conservatively without surgery. Risk of skin complications. Skin irritation around the stoma is common and up to 40 people out of 100 will have it. This can easily be managed with creams, good hygiene, and proper application of the stoma bag and flange. Thank you for participating. Now, to further guide your decision, please click the Question and Answers panel and answer all the questions. Once you complete your answers, simply click the Submit button. You will receive an email that contains all your answers. You can print out your answers when you see your doctor.